speak on improving outcomes in curable lymphomas with constrained resources. And I will, in the times of new therapies, targeted therapies, precision medicine, still stick to the old, because even with the old therapies, we can actually make a lot of differences. And towards the end of the talk, of course, nothing will go forward without new therapies. And I will give you some idea of the information as well as experience with new therapies, which will change or transform treatment paradigms in times to come. Needless to say that I learned the ABC of lymphomas here at Tata Memorial Hospital in Mumbai and worked there for about 25 years with extremely extraordinary colleagues, many of them who are in this picture, and Dr. Saikia is chairing the session, and some who are not here, but I will definitely mention as my talk goes on. Lymphomas did not start with me in Tata Memorial Hospital. The study started even before I was born. And the first study belongs to 1941 to 1960, which was published by Dr. P.B. Desai in Cancer in 1965. Everything that they thought was lymphomas, whether it was lymphosarcomas, Hodgkin's, reticulum cell diseases, and many unclassified things went into what made 2.35% of all the cancers in the first 20 years of the institute. And strikingly, there was a male preponderance at that time, which was 4.5 to 1. I tried to find when things happened in Tata Memorial Hospital, and Dr. Tapan will help me. This is the first register which they maintained, and when you open it, it shows 1979 written by Dr. Advani. And I guess this was their database, the way they collected and meticulously kept the numbers of patients. We had many such registries in lymphoma, and some of them are in the background of this slide as well. The first data that began to come out was mainly from the pathology department under the guidance of Dr. Anita Borges, Dr. Soman, and they actually showed that the aggressive lymphomas were much more common in our population as compared to low-grade lymphomas, as compared to the developed world, and also that the median age of patients presenting to our hospital was at that time about 45 to 46 years. Simultaneously, the clinics were no less. This is a protocol that was developed by everybody who was there in the lymphoma clinic at that time, and lymphoma clinic was the first MDT in Tata Memorial Hospital, which was also started much before I joined the institute. You can see that there was a research component to everything that they were doing. When they were giving treatments, they were looking at the role of maintenance. They were looking at the role of what an additional drug did to that particular chemotherapy regimen. And again, you can see Dr. Advani's writing at the bottom to say he will give local RT to patients who have large tumor masses. This handwriting is something that I think in future we will not see, but I cherish these because I have been through these clinics and I have learned a lot from them. This is Dr. Nair, CN Nair, who would meticulously keep all the numbers in the lymphoma register, and we would get a chance to take them up and analyze and make our papers at that point of time. One of the treatments that was happening when I joined was the continuous shock. It was a rather intensive regimen, but it was all the first generation chemotherapeutic drugs which were put together in an aggressive manner because a large number of these patients were of pediatric lymphomas, and it kind of mimicked the ALL-like treatment with maintenance, local radiotherapy, cranial prophylaxis, and maintenance. And so it was a long drawn-out treatment. And for adults to be able to tolerate this kind of therapies was difficult. And we had lots of patients who would come flapping because they had grade 4 peripheral neuropathy, and that would remain for life. So we thought, we looked, the first published report of this paper was in Cancer in 1990. And the first 108 evaluable patients gave us an idea that the projected outcomes for these lymphomas was about 60%, and that many of them would get cured, as the plateau on the latter part of the graph shows. The hypothesis was that first generation chemotherapeutic drugs, if given rapidly, can allow minimal time for tumor regrowth and induce tumor cell kill at a maximum rate. Since I mentioned that the older patients were not doing so well, we actually looked at a randomized trial which looked at patients who were receiving CHOP versus the new continuous CHOP therapy. And at least when we looked at the survival curves, we did not find that in the adult patients, this kind of a regimen made too much of a difference. And it was, of course, a long duration and pretty toxic to some of the patients. We looked at the data in the long term, and again, you see that the curves plateau, which means people did get cured, but our outcomes in the adults with lymphomas was at 40% with the drugs that were available to us at that time. Around the same time, we had this paper which was published in Annals of Oncology in 1985, which was the MACOP-B therapy. The beauty of this therapy was, of course, it was intensive. It kind of took all the drugs that were available for lymphoma into the initial induction therapy. But the beauty was that it was only 12 weeks. And in the first 51 patients that they reported, it had a 100% overall response rate. The median follow-up for patients was 23 months, but the actual overall survival was 76%. So anybody who said we could change 40 to 76 kind of gave us a reason to change from what we were already doing. We did an initial pilot study of the MACOP-B regimen, and we were reasonably happy with the initial results. And so we went on to do a randomized trial because epirubicin was a drug which was just coming in at that point of time. And so we thought we will randomize patients to adriamycin with a safer cardiac anthracycline, which was epirubicin at that point of time. And this is the Excel sheet most meticulously maintained by Dr. Tapan and Dr. Gopal. And you can see that they mention the dates on which the patients got their 12 cycles. The last remark shows the follow-up chart and whether the patient was well or it was not the time of mobile. So we posted letters to patients to understand what their follow-up. And if they were in CR and well controlled, we just continued to write the last date of follow-up in order over here. We looked at the results of this regimen, and we did not have a similar kind of a feel and the mortality, at least in our hands, with high-dose methotrexate and the kind of toxicity that it caused at that point of time with no MTX levels was pretty high. As far as the cardiac toxicity was concerned, which was the primary objective of this patient, there was absolutely no difference. And so this is the first randomized trial which has been published from the Department of Medical Oncology way back in 1998. And again, if you look at the fag end of the curve, it appears that we did not cross 40% as the long-term outcome in the 211 patients who were treated between 89 to 93 and were followed up till 1997, after which this paper was published. The lab was competing with us. Naresh had joined the lab, and he actually began to tell us that all lymphomas cannot be clubbed together or chopped or MACOPed. You have to start thinking of lymphomas as B cell and T cell, and the treatments will be different in times to come. And this is the first large effort from Naresh's lab, which actually gave us an idea that 85% of our patients were B cell, 15% were T cell, and of the B cell, the largest number were diffuse large B cell lymphomas. We had improved on the registration books in the lymphoma clinic, and we have the lymphoma clinic registration data, which saw about 300 odd patients in 2000. And by the time it was 2010, we were seeing about 1,000 new patients a year. Again, high-grade lymphomas were the most common, low-grade lymphomas were less common. Some few lymphomas, despite Naresh's best efforts, remained not specified. When we looked at the epidemiology of the patients presenting to us, the median age was still 45 years of age, but the gender ratio had definitely improved, and it was not 4.5:1 anymore. So having learned the ABC of lymphomas, I realized that reliable data is important. Audits are necessary if we have to treat our patients appropriately, and all conclusions that are made from phase 2 studies are not necessarily beneficial to patients. and they should be validated either in a randomized trial or as real-world data. And with that, I moved to Tata Medical Center, Kolkata in 2012. We see about 2,500 patients of hematology. Few of them are benign. A large majority of them are malignancies. The largest number are lymphomas, which are about 500 to 600 at an average per year, of which about 100 are Hodgkin's lymphomas. About 400 to 500 are non-Hodgkin's lymphomas. Again, the B cell are about 85%, T cells are about 12%, and a few still remain unclassified despite best efforts. But the difference that we saw was about 30 to 35% were over the age of 65% presenting to the hospital over here, because we deal mainly with the regional patients in this area and are not really a reference center like TMH. And the median age suddenly increased to 56 years and the gender ratio also improved. What happens to all the patients of lymphoma who present to us, we don't really treat all of them. There are many second opinions who come after they have been treated outside, or many of our patients who go outside for second opinions, and some which we have to refer out because they just can't afford treatment at our center, or they are empaneled for other hospitals. So we treat about 50% of the patients who come as first-line naive treatment patients. And of this list of patients treated between 2011 to 2018 and followed up till 2020, the largest number is the diffuse large B-cell lymphomas. And so it is still important that we don't get away from the right drugs and the right doses, because I will show you that they still make a lot of difference in the outcomes of the patients. Having said that, we were treating with older patients. We looked at our data set of more than 200 patients. And needless to say that these patients are 65 years of age, but if we treat them with the right treatments and the anthracycline-based treatments and not fear anthracyclines in the older patients, their outcomes are just as good as the younger patients. If we cannot give them anthracyclines and we treat them with non-anthracycline-based therapies, the outcomes decrease by more than 20%. And for patients in whom we feel they are elderly, and so we should just dabble with something like cyclophosphamide or steroids or just add a little bit of vincristine, they don't really do well. And so it is not right to leave a diffuse large B-cell lymphoma not well treated, even if they are older. This is just to show you that we keep our data painstakingly, and we look at all the parameters like anybody else, anywhere else in the world or in the country. What came out interestingly, of course, was that rituximab seems to be making a difference in the patients, just as it has in all the other trials, initially in the older patients outside, as well as in the younger patients across the world for the last 2 decades. Rituximab was expensive, not always available to all patients. And so if we can give rituximab versus patients who cannot take rituximab, the outcomes are significantly different in the older patients. This is data which has always bothered me very much, because if you see every 5 years, India has somehow stagnated when it comes to outcomes of patients of lymphoma. Israel has always done well. Japan, who was something like us, has also improved. And so why have we not improved? And I think the answers come from the curves that I have shown you, and the next curve that I will show you, that if we treat our patients appropriately, we don't need too many new drugs, we don't need too many new modalities, we can just improve our outcomes. And this is not only a function of rituximab, this is also a function of socioeconomic status and our sometimes we are hesitant to give our patients the best drugs and the best doses only because we feel they're older and they will not tolerate. So somewhere we have to get out of the fact that someone is old or someone is young. It is fit for treatment and they must be given if it is a curable malignancy. When MabThera was introduced, we could hardly use it in patients. When the first biosimilar came up in 2007, we used it doubtingly. We never knew whether it will have the same effect. And so the rich and the insured patients got MabThera. But gradually, our experience with the biosimilars increased. And in the most recent data that we have seen now, less than 10% of the patients in a large series are treated with the originator brand. Most patients in India are treated with biosimilars. And from the data I have shown you, I think we have no doubt that biosimilars are just as effective as the originator brand. When we looked at our own data at TMC Kolkata, we were able to give rituximab to about half the number of patients who came to us in 2011-12. It gradually improved, and now after 2019, there is no patient from the hospital who needs rituximab and does not get. It is either through patient access programs or through philanthropy of the large number of donors that we have. When you have a large database, you can question and get answers for yourself. I have no doubt, like I have said, that the elderly patients with diffuse large B-cell lymphomas deserve the best treatment. Because if you will see the first graph, those who received more than 80% of the myelosuppressive drugs in their dose intensity did better than those who were given anything less than the full dose. There was a lot of hype about dose adjusted EPOCH. I was a firm believer. Dr. Tapan told me, don't believe in it. I continue to believe in it. But when I looked at my data, Tapan was right. Can we avoid anthracyclines in the elderly patients? Yes, we have to sometimes avoid. We do use Minichop in patients in whom we give anthracyclines also. And we looked at the data. If we replaced it with etoposide, what happened to these patients? So if you can't give anthracyclines, don't give CVP or BR. CEOP is a regimen which actually gives almost equivalent results. So having put up all this data, I also thought that whether I should continue to do it alone, or despite having burnt my fingers twice before, whether I should again join a larger group. And at that time, Dr. Ramesh Nimagada said that his OncoCollect software was ready, and if I was willing to take up lymphomas and put up a group across the country, he would be happy to give us the database for free. We also looked at other than the drugs, and this is Mohan's work, and I will take you through some of this work because we keep looking at drugs, but there are other factors which actually are equally prognostic in the outcomes of our patients. When the numbers are really small, you must join the big people. And so we joined the International T-cell Lymphoma Project for keeping T-cell lymphoma data, and I will show you a slide on that. And if time permits, the future is large data, big data, and we are not going to be able to do it ourselves. So we have started dabbling with artificial intelligence, machine learning as a collaboration of the academia and collaborative study from the industry. Coming to OncoCollect, which is a lymphoma registry, it was set up in 2017. And it was basically with a very simple objective. We have analyzed the first data, which is to look at the clinical presentations and outcomes of patients who received first-line treatment for diffuse large B-cell lymphoma. This is over 5,800 patients, adults mainly, who actually received treatment between 2011 to 2017 in 9 centers across the country. And we have about 1,961 patients together. And if we look at the internal validation of the data, the event-free survival and the age at presentation kind of validates our data, the early stage patients doing well, the young patients doing better. And again, if we look at the low IPI versus the high IPI, we look at the groups of treatment where group 1 is those who were best treated with anthracyclines and rituximab, and group 2 were patients who did not receive anthracyclines versus the group 3, then there is a significant difference in the 3-year outcome of these patients. Needless to say that anthracyclines and rituximab make all the difference in these patients. The 3-year event-free survival for our patients is now 66%, way above the 30 and 40% that we had seen 2 or 3 decades back. And the overall survival for these patients is 75%. What kind of surprised us or rather shocked us was that our early stage patients have not done well. And this is the importance of having your own data and looking at it from time to time. We all know that abbreviated chemotherapy with or without radiation has become the standard of care in patients who achieve a metabolic complete response. And you can do away with radiation in these patients as well, as long as they don't have a bulky disease. But this present series has shown that the results in early stage disease is inferior. And the reasons may be many, and our suggestions would be reducing therapy must be limited to highly selected patients who have undergone adequate staging, who have undergone adequate response evaluation before we actually reduce treatments in these patients. And again, in this paper, we realized that the salvage options are available for only 50% of the patients of diffuse large B-cell lymphomas who have relapsed and are refractory. And there is very little second chance for these patients. So ideally, the first chance is the best. And so we cannot get away from this fact. And when we went to look at how many of these patients actually received high-dose chemotherapy and auto stem cell transplant, it is feasible in less than 10% of this cohort. And this paper has been accepted and will be out in public, will be published soon as a series of papers which is being done for Frontiers in Oncology on real-world outcomes in lymphoma, which has been kind of piloted by our institute at the Tata Medical Center. There is enough data from many institutes across the country, single institute studies, and we had earlier done a national registry which had looked at retrospective data. We have now put up another OncoCollect registry which has looked up at data, which again is retrospective, but it has the advantage that these institutes have an EMR, and so we believe that it is a better and less biased way as compared to just collecting charts and reviewing charts, which was the thing that we had done earlier between 2005 to 2009. The median age in this particular decade has definitely increased, and we rarely see patients below the age of 50, seems to be going up steadily. The number of patients who have received rituximab in various series has continuously and steadily increased over time, and the outcomes have also been favorable after, I think, we have initiated giving better doses of therapy to our patients, as well as the biosimilars, which has made standard treatments much more easy to give in most of the patients in the institutes that participated in the particular study that I showed you. From the same registry, we have looked at Hodgkin's lymphoma, again, the same time period from 2011 to 2017. And we have over 900 patients, adults, who have been analyzed. In the 9 centers, over 90% of the patients get ABVD, over 85% of the patients respond favorably to treatment, and a large number of patients are alive in the first remission at the last follow-up. What was a little better in Hodgkin's lymphoma was 75% of the patients who are relapsed or refractory undergo treatment, and about, I will again show you the results of the relapsed patients a little later. So if you look at the first line therapy, our event-free survival and overall survival for Hodgkin's lymphoma in the 9 centers is just as good, and there were no surprises, luckily, with the data from Hodgkin's lymphoma in our set. So OncoCollect registry was an initiative aimed at analyzing real-world data in order to understand the lacunae in care and improve and modify treatments for the future. This study was a retrospective analysis of captured data, and we feel that the inherent bias of traditional retrospective chart review would be less in this, and so maybe the data is a little more reliable. What we taught us was real-world data is important in understanding the outcomes and current practices, especially if we have to have a reference point for initiating changes like de-escalating therapies, reducing long-term complications, as well as the favorable outcomes that we saw of patients who had relapsed or had refractory disease in this particular study. And this gives us the need to recommend that a second chance needs to be given to all patients of Hodgkin's lymphoma, even if they are refractory. Again, you said rare diseases. If you look at a population of 1.5 billion patients, then I think 30,000 lymphoma patients is a rare disease. And if everybody puts their efforts together, we should not be seeing the kind of mortality that was reported in non-Hodgkin's lymphoma or Hodgkin's disease for India from Globocon in 2018 in their future data collection from here. I said other than drugs, we have looked at other prognostic markers. This is Vikas's thesis from TMH in Mumbai, and he had presented it at the ESMO in 2012, where we were able to show that subjective global assessment was indeed a tool which could predict that response rates to treatment were better in patients who were well nourished. Mohan thought it was pertinent to revalidate this in another center, and so took up this as a prospective study to determine the association of pre-treatment cachexia with overall survival in patients with high-grade non-Hodgkin's lymphoma. And the tool we used was the same, which is the subjective global assessment, which is widely validated instrument for grading malnutrition and can be used to grade cachexia as well. We had 239 patients who consented to participate in this. We graded them as SGA A, that was the best nourished, B, intermediate, and SGA C according to a survey done by the patients themselves. And they were classified as A, B, and C. And you will see how well we can differentiate the outcomes of patients between the well-nourished and the poorly nourished. And most of the patients' losses are in the first part of the treatment, where they are either unable to tolerate the treatments, or they actually have infections which take away finances, and then they are not able to continue treatment. And so this was a paper that we published or presented at ASH in 2019, and concluded that pre-cachexia and cachexia are common in newly diagnosed patients with high-grade NHL. And cachexia at diagnosis as a determinant by HGA is a significant prognostic biomarker of the overall survival. So while we keep on dealing with drugs, we have to remember the social and the background surroundings of the patients and the kind of patients that we see, and make an attempt to do something in that direction as well. In today's world, new drugs are important. We haven't really had much luck with many new drugs coming in through clinical trials in lymphoma and leukemia. That has just started from 2018 after Vivek joined us. And so I will kind of say that most of the new drugs that we have used have been either on named patient access basis or compassionate access program. And this again is Vivek's hard work. We have used brentuximab, and I will show you some data. We have recently used polatuzumab in a few patients. And very, very recently we got sofetamab, which is a novel bivalent CD20 targeting T-cell engaging bispecific antibody, which everybody has been looking forward to. This has just started. Only the second patient has taken the first cycle, and so I will not speak anymore about this drug. So we had a group of 179 patients whom we have treated for relapsed refractory lymphoma between 2011 to December 2019. And out of this, 30 patients were treated with brentuximab bendamustine-based combination. They were all young patients. The gender ratio is 1:1. It was 63% of these patients were primary refractory. This combination is easy to give, very little toxicity. We give it in the outpatient now. And we also have a response rate, which is somewhere at 80%, with 62% of patients, some of whom were really refractory, achieving a complete metabolic response. We have transplanted about 57% of these patients. 26% of patients underwent an allogenic transplant because they were either refractory to 3 or 4 lines of therapy and suddenly went into a complete response, or because they had failed an autologous transplant and went on to have an allogenic stem cell transplant. And the results are extremely gratifying, with the overall survival and reasonably plateaued curves at 5 years of 75% and an equally impressive event-free survival for these patients who were otherwise hard to treat. There is enough data available from the country, and we looked at the retrospective analysis from 3 other publications, which have been relatively recent. Most of these patients were refractory or had relapsed after 2 or 3 lines and underwent transplant following chemotherapeutic drugs used as salvage therapy, and their results are just as good across the 3 studies. It is always hard to give a lot of chemotherapeutic drugs. The transplant-related outcomes become a little more difficult to handle. And so using targeted molecules keeps the patients in good general condition when they undergo transplant, especially if they have to undergo an allogenic transplant for any reason. Again, thanks to Vivek for bringing in a compassionate access program into the hematology department. From 2017-18, when it was activated, we had treated over 80 patients. The worth of these drugs is over 70 crores. And in lymphomas, we got the opportunity to use polatuzumab in 10 patients from the time it was FDA approved in 2019. So as early as May 2019, we started getting this drug for our patients. We have used it in 10 patients. It is another antibody drug conjugate of the anti-CD79B. This is the swimmer's plot of the first 10 patients and first 8 patients, and we feel that we have made a difference in at least the lives of 3 or 4 of these patients who have crossed 1 year of follow-up now and are disease-free. I said, when you don't have much to contribute alone, join the big people. And so the T-Cell project had completed their first project and were looking for partners across the world. And that time they requested us to be a part of the T-Cell Lymphoma Registry, which we joined in 2018. And this is the first paper only looking at the epidemiology, which was presented at the ICML last year. And we have a very small contribution, but at least we are there on the international work. So I have to thank the people who have actually stood by me in this last 1 decade and have helped me to allow me to collect, audit, and present all these papers and publish some of them now. The most important are the young girls in the front row. These are all our coordinators who have meticulously kept the data, done the research, presented all these papers at so many national meetings, and now have got their papers accepted at very many international forums, everything included from ASH, ESMO, and ASCO. So lymphoma management in TMC has been like everywhere else. It is service which leads to audits, to presentations, research, and publications, and we have benefited from our collaborations. In 2018, when we put up a national consensus statement of lymphoma management, we had to use all references and outcomes from international publications. As more and more collaborative groups in lymphoma come out along in India, I hope consensus statements in future will have data from the country. So Jyoti, if you'll give me another 2 minutes, then I will just finish the last part of my presentation, which is the importance of patient education. Patients are extremely important because none of this would have happened without them. So we can educate them. This is again something that I learned and started at the Tata Memorial Hospital when we used to have the Lymphoma Day for patients who had survived. We continued this Survivor Day program over here, and there have been many survivors who have become philanthropists for us. This is celebrating the World Lymphoma Day, which went on every year till 2019. And now it has been taken over by the coordinators who actually arrange everything for the Lymphoma Day. And we have a strong patient base, which kind of waits for the Lymphoma Day to happen. In 2019, a group of patients said, we are well for a long time, we now need to do something. And they have become our counselors for our patients. So they give their numbers, they give the time, and they are all busy people. They are principals, they are IT professionals, they are lawyers, they are business people, and they are people working in MNCs. And they have formed a group which we termed as ASHRAE, which we inaugurated in 2019. And they carry on a lot of work that otherwise we would have to do ourselves. Last year, or 2020, was the year when we could not have a lymphoma day for fear of corona. And a patient then came up to suggest that they would put up a platform for us, which we can use for free of cost for the next 15 years. And with that, the Lymphomap was born. It is an artificial intelligence driven platform. And in times to come, it will be more than a platform alone for discussions and information. We hope to learn much more from it. At the moment, I am stuck with understanding what is machine learning, but in times to come, I hope I will have more information on deep learning, Bayesian AI, and analogical AI. To me, these are terms now, and I will leave it at that. We have begun to put in lymphoma data again into this system, which is being helped by IT personnel in the Lymphomap group. And I will show you these slides just to maybe confuse you. But we hope that in times to come, the data that we put in will be able to prospectively predict what will be the outcomes of the patients. And in times to come, also predict which are the patients in whom we need to intensify therapies. This is all for the future. And I think my colleagues will do a better job when they present in years to come. So the way forward is, please continue using the standard of care in the right doses at the right time, because these treatments actually make a difference of more than 20% in the populations that we are treating. And this needs to percolate not only to the institutes that manage lymphomas, but also into all the areas where patients of lymphoma are treated. I believe strongly that collaborations on a common data collection platform are needed for this country. And we now have many collaborations which are happening all over the place. We need patient treatments to be tailored to their needs, depending still on the facilities available in terms of diagnostics, imaging, and socioeconomic support. And support groups go a long way in assisting them. And we need to handhold them in the initial years till they are independent and fly high. Big data will be needed, and digital technologies is something that all of us should dabble with, whether we understand or not, because in times to come, we will use them for certain. And I sincerely, from the bottom of my heart, thank you for the opportunity to present this ISMPO oration. And like I said, it is very special to me because Dr. Tapan and Mohan are chairing my session. Jyoti has done most of the work for this particular meeting, and the meeting is being held by TMH, which is also very dear to me. Thank you very much.